Hi, this is Dr. Kristof. If you are seeing patients who remain mysteriously unwell in the months after COVID infection, join me for Bioceuticals Clinical Mastery, the Post-Viral Syndrome, on June 8th, where I will cover the key relevant strategies in post-viral syndromes, including immunometabolism, endothelial dysfunction, and mast cell activation. Go to bioceuticals.com.au to register.
This is FX Medicine, bringing you the latest in evidence-based, integrative, functional and complementary medicine. I'm Dr. Damian Kristoff, a Melbourne-based chiropractor and naturopath, and joining us today is Ben Southam. He's an accredited exercise physiologist and a director at Pace Health Management in Victoria. Drawn to exercise physiology by his love of the human body at school, Ben attended Deakin University and completed his undergraduate in exercise science, followed by a Masters of Exercise Physiology. Ben enjoys the diversity of conditions he gets to work with on a daily basis, supporting his team in their professional endeavours and the amazing people he gets to meet. In his spare time, you'll find Ben keeping active, running the paths of Bayside, playing around at golf, I've got to tell you, drinking a coffee, and also enjoying baby chinos with his daughter. Ben, thank you so much for joining me today. It's a pleasure to have you on our podcast.
No worries at all, Damien. Thank you for having me and giving me the opportunity to talk a little bit about exercise physiology.
Ben, it's I've known you for it feels like eternity now, 10 years or so I think it would be since you've come into Sandringham, and I've always been fascinated because for a long time you had personal trainers kind of paving a way, and then there's exercise scientists coming into the space, and there's exercise physiologists in the space, and there's physiotherapists kind of in the space, and I've never really known the difference between each of them, except for maybe there's some extra education. Could you shed some light on the difference between, say, EP and exercise science, or personal training, for example, just so that people who are listening, our other practitioners who are listening, could maybe get a sense of how highly skilled you guys actually are?
Yeah, sure. Look, it's probably one of the number one questions we get on a daily basis is what's the difference between us and physios and us and personal trainers. To just explain it, I suppose, is an exercise scientist is someone who's done a 3-year undergraduate course in exercise science, which exercise physiologists have also done. So what that enables those people to do is they can go out and treat people who are apparently healthy, and they really work in the space of preventing chronic diseases and helping people to maintain health and well-being. From that 3-year undergraduate to become an exercise physiologist, you do a further 18 months as a Masters of Exercise Physiology. And this really gives you the tools and skills to deal with people who have chronic diseases, and I suppose is much more evidence-based approach to managing these conditions. For example, diabetes, heart disease, stroke, mental health, and so forth. So as an exercise physiologist, I'm also an exercise scientist, and in our clinics we do have exercise scientists working with our apparently healthy clientele, and then our exercise physiologists then deal with more chronic health and chronic pain areas. In regards to physios and exercise physiologists, we work really closely with physios and chiropractors and osteos. But, as exercise physiologists, we don't do any hands-on treatment, and we don't really work in the acute injury or, the acute space. So to give an example I usually give is if someone, say, has done, an ACL tear, usually they'll seek physiotherapy treatment for the acute phase, pre and post the surgery, or if they're not going to do surgery, pre or post injury. And then after that acute phase is done, that's where exercise physiology can then step in and sort of go that more long-term approach with rehabilitation and then moving towards that performance as well. So I hope that just outlines a little bit of the differences between those 3 subgroups. In regards to personal training, I suppose the main difference we have is as exercise physiologists, we have provider numbers as well, so we can work with Medicare, work cover, TAC, and we also have a governing body called ESSA, which then ensures that, there's rules and regulations we have to work within, and standards, which is, I suppose, slightly different to the personal training scope.
Yeah, well said, Benno, and thanks so much for being so clear on that, because I think there's been certainly a misunderstanding of where potentially EP fits into. I'm going to shorten exercise physiology to EP if that's okay for everybody else.
Yeah.
I know you can't answer me, but I'm just going to assume that you agree that EP is okay to call it. We're going to call exercise physiology EP. I think it's such a great. It's a pearl for me to understand that you guys have done a 3-year undergraduate exercise science qualification. Then you've gone on to do a master's program. And that's the reason why you're able to manage these chronic disease issues. And obviously in naturopathy and the natural medicine space and integrative general practice and herbal medicine, nutrition, dietetics, chiropractic, all of these professions, we all deal with people that are in either the mode or mindset of prevention of disease or in the management of chronic disease. And so to know where you guys slide into that, I think is super important. So thanks for clarifying all that for me, Benno, and for everybody else too. That's fantastic. Benno, the field that you're in is definitely emerging. It's growing at a rate of knots, and there appears now to be, I suppose, a greater need for the work that you do, more so than ever before. We've got diabetes spiralling out of control. We've got obesity rates. It's now more common to be overweight or obese than to be of normal weight, which I find mind-blowing, particularly here in Australia. Cancer is a chronic disease. Heart disease is a chronic disease. There's so much. What are you guys kind of seeing in your practices, and what does your research kind of give us hope towards you're able to help out with?
Yeah, and then you chuck all the COVID stuff recently on top of that, and it's a bit worrying at the moment. Look, to be honest, most recently we are seeing a lot of mental health, which does have a correlation regarding COVID-19 and the isolation requirements and that's whatever all the lockdowns that have been going on as well. So, seeing a lot of people with mental health, and now that we're sort of emerging out of hopefully that space, I'm predicting, and we are seeing a lot more, I suppose, chronic health plans being referred to us. So potentially people who may have slipped through the cracks during those lockdowns, where they may not have seen their GP as often, and they haven't had their regular health checks. Now it's sort of a bit of that catch-up model where, a lot more type 2 diabetics coming through, heart disease, as I mentioned, mental health, so a lot of depression, anxiety out there. So, that's sort of what we're seeing in clinic. And I suppose from the research point of view, look, we see like so many different diverse conditions every day in our clinic, and the research is so diverse that it's sort of covering all different topics that we see in clinics. So one website I will advise that a lot of listeners have a look at is what's called exerciseismedicine.com.au. And that's actually a website that's developed by our governing body, Exercise Sports Science Australia. And on there, they have a fact sheet page, which is available to everyone. And basically what it is it's just a constantly upkept fact sheets for distribution and for health professionals to read through that shows them what the most up-to-date research is on exercise prescription for all different conditions. So, there's fibromyalgia on there, there's mental health, there's type 2 diabetes, anything that's within the EP scope is up on that website as well.
Oh, wow, that's fantastic. So that's exerciseismedicine.com.au. So go and check that out, everyone. And we'll give that link in the show notes as well so that everyone can get access to that. I think that's a really important and certainly helpful resource. Thanks, Ben. That's great. I think there's a couple of levels when we consider evidence, and I think almost every health profession it sits in this same space, is that there's a tendency to desire the gold standard of research in the clinical trial, the double-blind placebo-controlled trials. But how often do you see someone, or two people with exactly the same complications of type 2 diabetes? And then how often would you see somebody with exactly the same complications associated with an ACL tear? My question is then to you, Benno, do you find that sometimes it's difficult to get that robust evidence because of the difference in the way in which people might present, their ability to do certain exercises. And then should we be considering and consider it more so of the practitioner and patient interaction component of evidence-based medicine in this particular regard? I'd love your thoughts on that, mate.
Yeah, definitely. Look, there's, everything that we do in clinic is geared towards evidence-based research. But you do need to obviously treat the person that's in front of you. You would probably prescribe the gold standard, best research-based approach. But if that person doesn't understand or is not capable of doing that, you've got to try and work with that individual to steer them towards the best outcome that they can get. There's a lot of health behaviour change we need to conduct during our assessments and our treatment to try and get people understanding why things are important. But you also got to understand what that person likes and what's going to be the most important thing for them to do to then do long term, and then to become self-managed as well. If someone doesn't love running, you're not going to give them running, or if they have a real aversion to squats, you might have to change and give them something different that they will enjoy or they may, do long term. So yeah, it's a very, as you would know, Damian, with your work as well, it's a very much goes part and part with trying to work the best, I suppose, exercise prescription in with that individual as well, and trying to work with all different comorbidities and also, preferences there. So it's a bit of a fine balance to get that end result, which is, for us, it's all about trying to get them empowered and self-managing their chronic health conditions, because a lot of the time, it's not going anywhere. It's going to be there for the next 10, 20, 30, 40 years. You've just got to try and enable them to get that self-management and that long-term outcome.
There's a few amazing points in there. And I think one of the things you raised there, Ben, is that these people who are in chronic disease, for many of them, it's going to be about managing this chronic disease. It's not necessarily going to be about cure. Some of them will get there. Some of them will be able to adjust their full lifestyle through different types of prescriptions, whether it be pharmaceutical prescriptions, herbal medicine, nutritional prescriptions, exercise prescriptions. They'll be able to manage that chronic disease and maybe move themselves out of that chronic disease, which would be unreal. And I can see that happening for heart disease and probably relatively easily, and also type 2 diabetes. But for other, long-term diseases, could be a bit more complicated. But I love that personalised approach and that readiness to change model that you alluded to there, Ben, as well. And that readiness to change piece, I think, is great. And I'd love it if you could maybe just step us through maybe what a consultation might look like, your initial consultation. Because in my mind, when I walk past your practice, I see this nice little beautifully presented boutique gym space where people can feel comfortable. But I just don't know what it is. It's like this mystery box. People walk in there looking happy and they walk out looking even happier. So can you take us through what a consultation might look like with these people?
That's great to hear. Look, and we do that with a purpose, because a lot of people that we see may be a little bit intimidated or might not enjoy that sort of gym mentality. And the people that come into our clinic are people that may have never touched gym equipment before, or they've never experienced, structured exercise, or might be, a 94-year-old lady who doesn't really want to walk into, a really loud gym. So we try to make our clinics very approachable and more of like a family feel when people come in. But the way we treat has changed so much when I graduated to now. When I first left uni, I used to address my initials very, very structured, and I would spend, half an hour of planning and get all my questions ready and try and really, evaluate, why each person's coming in. Whereas nowadays, to be honest, when someone comes in for the initial consultation, it's normally the one question I ask is, tell me a little bit about yourself and why you're here. And I sort of try and talk less and let clients talk more to try and get to the deeper understanding on what's actually happening, what they're looking to get out of it, and sort of how we're going to get from A to B. And then I try and, steer around that and try to develop a really nice action plan so that they can understand, the requirements of what they need to do to get to their goals, both from us and from them. And then we work around the programming around that and try to set up some specific goals and structures around helping them do that. We're really there as a bit of a support person for them and a bit of a supporting coach and trying to keep them on track and educate them and really delve into their why, about why they want to do their change. And then we try and really put onus on the client to action it and to get good results. So that's a very quick, I suppose, intro into the initial. Obviously, we do a lot of objective measures. So we'll do all the blood pressure, heart rate. We'll do objective measures in regard to muscle mass testing if that's part of their outline. We'll do some cardiovascular testing so that we've got really nice, clear objective measures from the start. And then we'll usually implement this throughout their treatment plan as well, just to assess progress.
Yeah, nice. So their progress is always managed. It's always monitored. You're looking at, I suppose a set of outcome measures, whether it be, as you said, muscle mass, shift and change, and that's difficult to achieve. Could be weight loss maybe. Is that something that you guys might consider as well?
Yeah, we do. Look, to be honest, I don't ever weigh anyone. I've gone way away from scales these days.
Sure.
We'll do waist circumference measurements. I more like to develop and educate people on more the benefits of, strength training and more the habits and the routine behind it all, because it's more about the process apart from the result, if that makes sense. So I really want to try and drive into them the process to get from A to B rather than focusing too much on B, if that makes sense.
Yeah, and I love that. And the reason why I asked that question is a bit leading. I didn't tell you I was going to ask that question. Sorry about it. But the reason why I snuck that one in there was because there's people listening to this podcast right now and trying to make sure that you're not competition. And the reason why I say that is because in the health space, there's a lot of people that are in private practice and they kind of see a patient as someone that becomes theirs, it becomes a property of, and as opposed to a patient being someone who's seeking the care of multiple practitioners to help them be healthy. They need support, they need help. Where I see you guys kind of dovetailing is that it's a supportive, co-managed approach where people can get exercise prescription to assist them in whether it be the nutrition model or the pharmaceutical model or an integrative model of care, and you dovetail into that. And there's another level there which I love to talk about, which is a third-party endorsement. So a third-party endorsement for me, Ben, is that there's a endorsement of your ability and in reverse. So, for example, if I've got a patient that I'm sending down to you, I'm going to say, Ben's a great practitioner. He works unbelievably well in the exercise physiology space. He'll be able to prescribe exercises for you, monitor your progress, monitor your condition, and make sure that you're moving in the right direction. And then the flip to that would be that Ben would say, oh, great that you've come up here. I hope you say Damian's a great chiropractor and he's able to manage the components of your care that I don't manage. And that little piece, that little discussion there helps the patient kind of see the space between the practitioners. There is always going to be some degree of overlap. There'll be some degree of agreement on, a course of care or a progress of care or a program of care. But the endorsement of each other strengthens the resolve of the patient to get a better result. And I love that we do that. But the reason that I'm saying this for the people listening to this is that that's how you can build that little third-party endorsement, that promotion of your care that you provide through another practitioner. And you've got that space to be able to do that, Ben, which I love. And I wonder too, Ben, then with your patients, when patients kind of come to you and say, I'm following this nutrition plan from my nutritionist or my naturopath, what's the conversation that you might have with them about that nutrition plan in conjunction with your exercise plan?
Good question. From the nutrition side, our studies are very limited in that. So to be honest, I would probably leave all that to the treating clinician who's dealing with all that nutrition side of things. Mm-hmm. From our perspective, we would perhaps just liaise with that clinician on what they're going to be doing with us, and so that clinician then has understanding of the requirements that they may need to change. So, for example, if the client's going to move into, a heavy 8 to 12 week strengthening phase to try and really increase muscle mass and muscle strength, that requires different demands from a nutrition side. So just be more, as you were mentioning, throughout, just that liaison between us and the other clinician, trying to let them understand what we're doing. They can educate us on what they want us to reinforce as well, so that client then has the best outcome, So more just working closely with, different professions that have different expertise than us, and trying to get that end goal as best outcome for everyone, to be honest.
That should give everyone listening to this great confidence to know that you can include EP in your care plans for your patients, and feel very safe and secure that there's not going to be conflicting advice given there. So, it's all about swimming in your lane and making sure that you're working together at the same time. I think that's really important. Could we just jump to physical activity prescription, if you don't mind, Benno? I just kind of want to understand, how do you do it? What's the language that you might use with your patients, with your clients that come in? What are you saying to them in terms of what is a good prescription, and how would you progress with that? Do you progress with that just based on your outcome measures, or does the patient say, "Oh, Ben, look, I think this is a little bit too easy. Can you step it up a little bit and to rein them back in?" How does that prescription go?
Yeah, look, it's a bit of both, to be honest. There's two different types of prescription. There's the physical activity prescription, and then there's exercise prescription. So, say, let's use an example of a diabetic who's come in. Physical activity is basically anything that gets your body moving a little bit and performs some energy expenditure. It's usually non-structured, so it's things like, taking the stairs rather than lift, parking further away from the station and walking that extra 10 minutes, and things of that nature, whereas exercise prescription is much more structured and managed, I suppose. So physical activity prescription we use perhaps a lot at the start. So if someone's done nothing and is really new to the area and they're maybe a little bit nervous and overwhelmed about coming in to see us, some strategies we might use just to start to improve their exercise capacity might be, hey, Bob, this Saturday I want you to, go out with your kids and just walk around the oval and have a bit of a kick with them. Just get the body moving a little bit more than you are at the moment, trying to increase just in general how much they're moving throughout their week so that their body starts to get used to, that extra loading. It's also a bit of a nice way to start with those people because it's less daunting. It's a bit less structured, so there's more flexibility in it. And it's a bit of a more sneaky way to get them moving a little bit more. And then from there, we'd move towards the exercise prescription, which is, where all that evidence-based aspect is. At the start, we definitely go lower load and a bit higher reps, just because if you're seeing someone who's very new to this, strength or cardiovascular fitness, you don't want to firstly, scare them away and make them really sore and look really negative on exercise, which I think a lot of people do see exercise as a punishment or something they have to work really hard, whereas realistically, consistency will always outperform intensity. So
nice.
Just try and instill that within their life. And look, I never ever put finish lines on anyone as well. I always like to just sit down with them and go, look, you tell me when you feel like you're at a stage where you don't want to progress anymore, but we can just keep progressing and keep pushing you and sort of keep improving your exercise capacity to a level where you're happy. And then from there, then we can go into maintenance phase.
I kind of love that. I really love that because there's some degree of direction there from both the patient as well as the practitioner. And I was interested because one of my questions was when's it okay to pull up and say, this is just me? So let's say, for example, someone's, being given an exercise program from you guys, as well as their movement prescription. When's it okay for the patient just to say, Ben, this is as good as I want to get? Do you ever say, oh, come on, Damo, you can get better than that? Or, I know if I've ever gone to, and when I say if I've ever, I used to go to F45 all the time. If ever I felt like that was enough, I'd get screamed at, like, get moving, give me 20, that kind of thing. Obviously, that's not what EP is, but do you use techniques to kind of keep people going and push themselves further? Do you feel that sometimes people don't really know their true potential?
Yeah, it's a hard question, that one. Look, it depends on a number of things. If they're coming in under a chronic health plan and their blood lipids are not where they should be, their glucose is uncontrolled and things of that nature, then we definitely use motivational interviewing techniques. We'll definitely try and educate them further on why they need to do more or how they can improve their health picture. But say you got someone who's just your weekend warrior who's running their 10Ks every Saturday, they're feeling really good, they're doing their 2 strength sessions a week that you've given them, they don't really want to push any further and sort of happy with their current capacity, then that's happy days. That's getting your A to B and getting to your end result. So from there, we'll just give them some simple strategies around how they should be maintaining what they've got. And then after that, it can be a little bit about, trying to just keep the variety up so that, they stay engaged in the program and stay at their current level. So as everyone knows, everyone likes variety, and variety is the spice of life. So you just got to use some different strategies just to try and maintain their exercise capacity.
Yeah, I love that. It's again measured and metered and monitored and kind, which I think is really nice. Kindness. It's a ripper. Now, you touched on COVID earlier on, and obviously there's very little evidence around what it is that we can do for COVID because it's emerging. It's only a couple of years old. So we are seeing a lot of people coming in with long COVID symptoms and complications associated with COVID, whether it be respiratory tract or muscles or overall fatigue within the body. How are you guys addressing that? And have you noticed that there's an approach to, I suppose, getting back into exercise after COVID that seems to work better across the board? Or again, obviously there's individualities for each and every single person, but how are you guys approaching this post-COVID time?
Yeah, look, there's definitely just more up-to-date research coming through as this sort of pandemic continues. And we've actually had one of our students who's come through our clinic recently do a full evaluation for us and have a look at the research around how you should be reintegrating back into exercise post-COVID. So I'm happy to share that with you as well if you'd like to put that in the show notes for questions to look through. But
that'd be great.
As someone who recently also had COVID, courtesy of my daughter, and I was asymptomatic, I can very much advocate for a slow and progressive return back to exercise. I was a bit brazen in my approach and sort of 1 week post tried to go out for a nice sort of 8 to 10K run and definitely felt the effects of having no symptoms, but felt the effects of having COVID. What's sort of being suggested at the moment is really sort of almost like a 5 week build post symptoms. So they're sort of saying, after your symptoms have subsided for 1 week, we sort of look at a 5-stage rebuild. So looking at firstly just doing some really gentle breathing, stretching, balance exercise in the first phase, and then slowly progressing towards, lighter duties such as, yoga, some lighter yoga, walking, some light strengthening work. And then as the phases go on, you're slowly returning back to what you're doing pre-COVID. There's some guidelines around, when you shouldn't continue to progress, symptoms are returning, or if your fatigue's getting worse. And there's a bit of a diagram I can share with you about this, but there's different things that can sort of, educate you on when you should just stay in your current phase before progressing. But I'd probably just stress for everyone here listening to really respect, if you had COVID, just respect the progress afterwards. So just not trying to be the hero in the first sort of 3 to 5 weeks, just really trying to, listen to your body, listen to how you're pulling up, analysing your fatigue levels and your sleep quality and your stress management as well, and then just giving your body time to get back to where it was, because you just don't want to prolong the effect of what you've just gone through.
Yeah, great point. Great point. And, obviously everyone's going to be different. I've had this tickly cough thing for, I don't know, it must be 6 weeks now. It just doesn't want to go. It seems to get worse in the evening. So fortunately I exercise most of the time in the morning. But this tickly cough thing, which is a post-viral thing, it's very common with all kinds of viruses, can persist for a long time. That's as bad as mine gets, but some people have got this extreme fatigue and some people have still got joint ache and body ache. And so I think it's really important just to go easy and, regardless of what your health philosophy is or what your views are on, how this infection is playing out, I think it's really important to just, kind of manage the expectations of your patient because they may be keen to get into it sooner than what they should be. But you've got to be sensible in the way in which you're prescribing movement to these people for sure.
Yeah, definitely.
Ben, there's a great space these days, NDIS, and, I know a lot of people work in that space. You and I have got patients that we share in that space. And the reason why I wanted to just quickly talk about this is because not all practitioners have access to NDIS. And it's a fascinating little space that's been set up by the government, and I think it's really great. And patients who can access NDIS and then access practitioners within NDIS tend to be very, very happy and very, very satisfied. In that space, do you find that there's a willingness to participate, or do you feel that sometimes people, like in other spaces, you feel that sometimes people just expect you to do all of the work and they're not going to do the work? I don't want to say here that there's a group or a subset of people that don't want to work, but I'm always interested to find out whether or not something's working. So, I'd love to know whether or not you've got some ideas around how NDIS could work better, or, whether or not you think it's working really well as it is.
Yeah, the NDIS is massive. Probably doubled our businesses since it came in.
Yeah,
and it's just absolutely fantastic for people who are under the NDIS to have that level of support and that the clinicians available to them to help manage their conditions. So it's a great thing that's come in for people who are under it to access health professionals that they need, to give them the support that they need. Looking at our clinics, we see, as with all our clients, quite a diverse range of people under the NDIS, from mental health to Down syndrome to autism, and within that there's different scopes and different levels as well. Each perform their own challenges. Some highly motivated and come in and they get really good results, and then on the other side with other clients, if they're really struggling with mental health or schizophrenia, or they have some other comorbidities that really affects their motivational levels, it can be difficult to try and work with them to improve. But I think the underlying aspect is they've got that support and they've got that available to them to hopefully improve their long-term picture, and it's a lot more than they used to have, which is great. I suppose overall, from the overall picture of the NDIS, I think it's just fantastic.
It's so good. I'm rapt that you said that, Ben, because there'll be people listening to this podcast that will have people with mental health challenges who may not have exhausted all of their opportunities, all of the support that's available to them. And again, this goes back to a multimodal approach to their care. So let's say, for example, a nutritionist or a naturopath has a patient under care who's certainly suffering with mental health issues. They may not have actually spoken with their GP, necessarily about that, for fear of, a prescription that they may not want to go on to, or for another reason. Maybe there's some embarrassment or whatever else, or maybe their main trust goes with another practitioner. So, but the encouragement of the practitioner for the patient to speak to their GP, their primary healthcare provider, to enrol them in accessing NDIS and other types of support, I think is really important. And it takes, for some people, the financial burden, or lessens the financial burden for a lot of people to access this kind of care. So, if you're there listening to this and you're thinking about Mrs. Blogs and you're thinking, oh my gosh, maybe I should or could recommend that she goes back to a GP to have some, question time and some consultation about how they can get support, feel safe in knowing that it's a really great place to go. And of course, that's what you're looking at there. Ben, with a mental health issue, there's challenges there, right? There's a lot of mental health. The last couple of years has presented a lot of mental health challenge for a lot of people, whether it be anxiety or depression, to even just feeling forlorn, lacking motivation. What's the approach with exercise? There used to be, a commentary, and I used to say this a lot in my presentations, that if you walked for 30 minutes a day, it'd decrease the impact of cortisol in your system by about 50%. What's the kind of discussion these days in around exercise and movement and mental health?
Firstly, it's about enjoyment. So trying to work with them about what they enjoy doing and trying to work around and improve that area. The more I do this as well, sometimes a lot of our consultations might not be even regarding exercise, especially people with chronic pain, and looking at the biopsychosocial approach to helping with chronic pain. There's breathing techniques, there's addressing sleep quality, there's looking at stress management. For example, the other day I had a lady in the clinic who was going through some chronic pain flare-ups, and she came in, and her homework for the week that I gave her was just to go and put on a really nice podcast that she wants to listen to. Maybe it was this one, and just to go for a 20-minute walk, listen to a podcast, just to try and, change her mind a little bit, just have to think about something else in the day as opposed to what she was currently doing. So exercise prescription can work in that way as well. It might be, go and talk to a friend and try and meet up every Sunday for a 20-minute walk so you get that socialization to it. But on the flip side, that also makes that person have to call that friend if they're going to cancel. So it sort of helps them to keep compliant with their exercise program. And realistically, what I tell them is if you can try to commit to, say, 2 to 3 weeks of this stuff where we're putting in simple strategies around things that you enjoy with people you like, with music or podcasts you like to listen to, maybe to an awesome cafe that you love to go to where they've got the best coffee and you can just try and plan in your week to walk to. After 2 or 3 weeks, hopefully they start to feel the benefits of that exercise or the increased movement through, endorphin relief and decreasing cortisol, and their mental health maybe hopefully improving, and that starts to then get that habits and that compliance going, and then they start to realise benefits of it all. Sometimes less is more, and you just need to start really small and try and keep it really realistic for them. And then after they sort of get the hook and they start to enjoy it, that's where you can start to get a bit more exciting and build it up. But everyone's different. There's always different approaches. Never underestimate the power of just listening and talking with your clients. It doesn't always have to be coming in the clinic and working really hard. Sometimes it might be just a sit-down chat and a bit of a brainstorm and a bit of an action plan session where they just need to feel a bit more in control of what they're doing and see what they want to get out of it.
So good, Benno. So good. There's been so many pearls today, and I think for a lot of people listening to this, you'll have got that EP can fit into your healthcare plans or your management plans. You can see that the individualised approach is so important, that measurement's absolutely crucial, that the application of EP and any therapy in combination with other types of practitioners and other types of treatment, and care plans is so important for the practitioners and patients' journey. Ben, thanks so much for joining us today.
No worries. Thanks a lot for having me, and any chance I get to talk about exercise physiology and increase that awareness around what we do and how we do it, I think it's invaluable for everyone and all clinicians. So thank you very much for having me.
Now, to get more information on Ben, head to pacehm.com.au, and on exercise physiology, go to exerciseismedicine.com.au. Thanks everyone for listening today. Don't forget that you can find all of the show notes from today and all the other podcasts that we've done, transcripts and all other resources on the FX Medicine website. I'm Dr. Damian Kristoff, and thanks for joining us.
This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
Hi, this is Dr. Michelle Bullhouse. Join us on FX Medicine next week, where we'll be talking to Dr. Gemma Sharp about all things body image. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode.